And well, there we go. Good evening, everyone, and welcome to Barton's Winter webinar on ankle arthritis. For those of you who were at the last one, I was just talking to Natasha. I did the last one here about 3 years ago on ankle instability, so it's been a minute. Time flies. We're really enjoying our time in Tahoe and feel very welcomed by the community. My daughter's loving the high school, and I'm coaching cross country now, and obviously we're working at Barton. So happy to be here and excited for this snowfall, and hope we'll get skiing soon. In terms of this talk on ankle arthritis, I have no financial disclosures. What that means is I don't have any stock, I don't receive any money from any of the products we discuss or any of the implants. I am an orthopedic surgeon, and so I certainly have disclosures. Um, I am still involved with the UNR, the Uniformed Services University, which is a military medical school. I'm deeply involved with the military still. I retired just 3 years ago, so I'm still helping with some of their charity work. But specifically to this talk, I am a member of the American Academy of Orthopedic Surgeons. And I run the foot and ankle program for that group, and I'll be referring to some of our policies in this talk. And I'm also on the Public Education Committee for the American Orthopedic Foot and Ankle Society, and I'll be discussing some of our outreach programs during this talk. This is our agenda. It's only about 30 minutes, so I have about 30 minutes of talking, and then we can open it to question and answer. Some of you may have points that you want to bring up or therapies that you've used that I don't discuss. I'm happy to hear them. Just like you, I'm always willing to learn. So the definition of arthritis, I had to look it up. I wasn't sure if it's Greek or Latin, but arthritis is a Greek term. Arthro is joint, itis is inflammation. But anyone who has arthritis or has a family member with arthritis knows it's more than that. It's cartilage damage, it's bone spurs. It can affect your motion, pain. It can be very debilitating, or even affect, not debilitating, but really affect your quality of life in terms of your athletics here in Tahoe. The anatomy. I like this picture of the anatomy. And when you look at the ankle joint, you can see that the ankle is made primarily of three bones or four bones. We only see three on this view. The tibia, which is going to be your shin bone, your talus, which is your ankle bone, and the calcaneus is your heel bone. Um, and so those are the bones of the ankle. When someone says they have ankle pain, they're pointing, and I have my cursor showing right now, kind of pointing to where their leg meets the foot. And so there can be a number of joints that are involved. It can be the tibio-talar joint, so the joint between the tibia and the talus. That's the classic ankle joint, and that can be one location of pain. Sometimes when you point to where your leg meets the foot, you're pointing a little bit lateral medial, and you're pointing at the subtalar joint, which is also involved in ankle motion. The subtalar joint really gives you your uneven ground stability. And so if you have pain with uneven ground, it's often the subtalar joint, not the ankle joint. And then finally, a joint called the transverse tarsal joint or the Chopart joint. This is the joint we have to lock out or release when we're pushing off with our foot. So when you're having pain with push off or with foot strikes, sometimes it's the transverse tarsal joint. And you can see how close that is to where the leg meets the foot. So it can be any of those three joints when we're talking about ankle arthritis. Our bones are connected by ligaments. And if you did not have ligaments holding the bones, we would just be a bag of bones. So you see this fracture over here where the ligaments are disrupted. Without ligaments connecting the bones to bones, the bones would not be stable. Sometimes in clinic, patients will mention the word tendon and interchange that with ligament. Tendons connect muscle to bone. Tendons are also involved in instability. And so tendons can pull abnormally or weakly, and that can lead to instability as well. But the ligaments are the structures that, as you see here in these yellow lines, connect bone to bone. I promise not to have any gross slides in here. This is one of the few slides from a surgery. So this is a scope where I have a camera inside someone's ankle. And a few things you can see is you can see this nice smooth cartilage. Cartilage is the smooth covering of bones. It allows the bones to glide on each other. One of my partners, Steve Avalo, describes cartilage as being as slick as ice on ice. It's very slick. So cartilage covers the bones. And then our ligaments in the next slide over here connect the two bones together. Luckily for us, the ligaments are named for the bones they connect. So this ligament here is the tib fib ligament. And if you go over to the x-ray, it's here in this yellow line, the tib fib ligament. And that's what a ligament looks like in the ankle through the scope. They're very clean, they're very strong. when a ligament gets injured for instability down here in this lower picture, you can see how that happens. They don't rip into two pieces typically. Ligaments are like horsehair; they'll stretch a little bit and then finally rip some. And so that's what a ligament looks like when it ruptures inside the ankle. And you can see that if you get the ankle back into the right place, ligaments can heal with time. Let's talk about biomechanics for ankle arthritis. The ankle has about 35 degrees of motion in the sagittal plane. That's your sideways view of the ankle, the view you're seeing here in this runner. And so 35 degrees up and down. When we talk about going up, we're talking about dorsiflexion. And we talk about going down, we're talking about plantar flexion. The plantar aspect of your foot is the bottom of your foot. So plantar flexion, dorsiflexion, about 35 degrees. But our ankles do more than that, right? So our ankles accommodate uneven ground. And so it's triplanar. They move side to side and the ankle rotates during motion. Uh, when you talk about running, it's actually 5 times your body weight coming across your ankle. And that just comes down to physics. That's velocity, acceleration. If you do the math, you can see that 5 times your body weight will come across this small little ankle bone when you are running. And most of that force is shear force, side to side force. And so if you've ever used sandpaper before, you know that shear forces is the best way to cause damage. And so you have a little bit of damage in your ankle and you have 5 times your body weight coming across the ankle, you can cause a lot of damage to that cartilage over those joints if they have cartilage damage. So biomechanics and risk. We talked about 5 times the body weight coming across the ankle. If you gain 20 pounds, that's 100 pounds more of force coming across your small talus. And so weight is a huge component of arthritis. And so we have to mention that when we talk about the biomechanics of ankle arthritis. The more important thing, however, is the alignment. And so if you have a ligament injury where the two bones are no longer connected and they become a little bit out of whack, as you see this bone here, where this ankle is in valgus, some of you might refer to that as pronation if you're buying running shoes, where this ankle is in valgus or pronation right here. And you can see how that leads to abnormal wear and tear on this part of the ankle bone. So ligament injury can do that. Muscle imbalance can do that. So if you have muscle weakness, our muscles of our ankle are almost like a horse chariot, right? They're well balanced. If one muscle is not working, your ankle becomes out of balance, and that can lead to abnormal wear and tear and arthritis. And if you have neuropathy, certainly your muscles don't have that proper control, and that can lead to arthritis. If you have an ankle out of alignment, just like a car tire, it's going to have abnormal wear and tear, and it's going to fail with time. Nobody would want to drive this car across the country. And so you really have to consider alignment seriously. It is a huge effect in ankle arthritis and in the biomechanics of arthritis. So arthritis types. There's a multiple ways or causes of arthritis. It's not just malalignment. This is a list of all the various types of ankle arthritis that are out there, and I'll go through these. This is the Cliff Notes version, but I'll go through these as quickly as I can. The most common reason for ankle arthritis, though, is trauma. So if you broke your ankle, if you have ankle instability, if you've had an injury to the cartilage, I'm sure your physician or provider told you, hey, you are at risk for arthritis. Trauma accounts for 80% of ankle arthritis. Inflammatory conditions like rheumatoid arthritis account for about 13%. And then just old age, wear and tear, living your life, about 7%. So more specifically, trauma causes arthritis. When this ankle dislocated and broke off the back of this ankle bone, that caused cartilage damage. And if you go up here to the scope picture, again, this is a camera inside someone's ankle who had a similar fracture of the back of the ankle. You can see this cartilage damage. It's no longer this nice smooth cartilage that you see here. Now it's fibrin, it has all this cartilage damage. You can see that this can get caught up as your ankle moves. If you have that shear forces, it's going to make this worse and worse with time. So this is cartilage damage from trauma that you see, and that's what it looks like in real life. Again, if it's out of alignment, like that car tire, that can lead to arthritis and instability in the same way. Inflammatory conditions. These are conditions similar to rheumatoid arthritis, and I'll go through these. Rheumatoid arthritis is the most common inflammatory arthritis that we have. We don't fully understand why people get rheumatoid arthritis. There is a genetic component, and certainly there are some environmental components to it. Regardless, once you've been diagnosed with rheumatoid arthritis, there are medications that can prevent and even slow down the disease so you don't develop arthritis requiring a surgeon. These are called disease-modifying anti-rheumatic medications or drugs. DMARDs is the word we use. So if you get on these meds early, they can really limit the effect that rheumatoid arthritis has on your joints and hopefully prevent your need to see an orthopedic surgeon. But if they fail, and sometimes they do, you'll be referred to ortho. If your disease is mild, you might just get steroid injections to assist your rheumatologist or primary care provider. Or sometimes you will need surgery. And so sometimes patients with rheumatoid arthritis do need surgery to assist with their pain in their joints. Other inflammatory arthritic conditions out there, reactive syndrome. We used to call this Reiter syndrome, but it's reactive arthritis now, often associated with urologic or urinary symptoms and eye problems. Psoriatic arthritis is typically associated with nail problems. Ankylosing spondylitis, spine problems are associated. These are less common causes of inflammatory arthritis, which can lead to an autoimmune response, breaking down cartilage and leading to arthritis. Infection can cause arthritis. Lyme disease, not as much out here in the West, but the Lyme disease can be transmitted by ticks. The bacteria spreads from that tick bite and causes that typical circle that you might see with Lyme disease. If you see that, get treated quickly. The treatment is 4 weeks of antibiotics as soon as possible. If the Lyme disease is left untreated, it can spread to your joints. And it's a very tricky one to treat because even if you get antibiotics later and you kill the bacteria, parts of that bacteria can stay inside your joints, and your body will keep fighting that bacteria. And it's the body's response to the bacteria that causes joint damage. So Lyme disease can result in about 25% of joint damage if untreated. Septic arthritis, we're really talking here about direct inoculation. So you're out in the woods, you fall down, a stick goes into your knee, and bacteria goes into your knee. Well, that's septic arthritis. You need to get that washed out, and then 6 weeks of antibiotics. You can have hematologic spread of septic arthritis. What does that mean? It means that the bacteria is somewhere else in your body. You have an ear infection, a tooth infection. That infection gets into your bloodstream, travels through your bloodstream to a susceptible joint, and can lead to a joint infection in the ankle. Uh, Again, surgical and medical management to treat that. And you can do well with it, but you have to really get treated quickly. Other causes of arthritis, neuropathy or neuropathic causes. So diabetes and idiopathic neuropathy are huge causes of horrible arthritis in the ankle. What happens here? Why would neuropathy cause arthritis? Well, many of you remember high school physics where you had the fight or fight symptoms, right? You're in the woods, you see a bear, your eyes dilate, all the blood runs from your guts down to your legs, so you can run away from the bear or the animal or fight. That's your fight or flight response. So your nerves affect the blood supply to various parts of your body. When you have neuropathy and you can't feel your feet or your leg, it's not just the sensation. The neuropathy affects your vessels too. So you have this, we call it autonomic dysreflexia, but it just means your vessels are no longer responding to the same nerve impulses that they should. And you can have increased blood supply when you shouldn't. And that increased blood supply can cause resorption of bone and cartilage and lead to terrible arthritis. And so you see that with diabetes and idiopathic neuropathy. A stroke is different. A stroke will cause weakness in the muscles, and that will lead to that imbalance, like that car tire I showed you earlier, where your muscles are imbalanced and it's just out of balance enough to where it can lead to arthritis. Polio is a virus. It is 100% preventable if we vaccinate. But polio, the virus, can get into your body and directly attacks your nerves, leading to nerve damage, muscle weakness. Charcot-Marie-Tooth is a genetic form of a nerve illness where the muscles become weaker and can lead to imbalance. There can be a couple tumors that cause arthritis. Both of these are benign, but pigmented villonodular synovitis, PVNS, is a tumor where you have proliferation of the synovium, it becomes thickened, and it's just very hard, and that can rub against your cartilage and cause arthritis. And then chondromatosis is one where that synovium, the synovial tissue that makes joint fluid, forms cartilage in the synovium, and then you get these little balls of cartilage that don't belong in your ankle, and they can run around through your ankle like a joint mouse, causing cartilage damage. So both of these are benign and treatable by surgery, but they are possible causes of arthritis. All right. So how does arthritis present? I think most of you probably know this. Pain. Pain is our main thing we care about, right? It hurts. You have a swollen joint. It's painful when you move. It's painful when you run, when you ski, when you climb. You have a hard time on uneven ground. You have decreased motion in your ankle. Um, those are all things that you'll see with arthritis. When you come into our office, we're going to watch you walk. We might just watch you walk past us at the front desk. Sometimes we didn't see that. We'll get you in the hallway and watch you walk to see what your joints look like as you're walking. We'll have this standing view to see if your ankle's in good alignment. If it's out of alignment, we're going to pull on your ankle, testing your ligaments. We're going to have you push to test your muscle strength. We're going to see if you have any imbalance. We're going to get weight-bearing x-rays of you. X-rays are our mainstay of diagnosis. On this left-hand side, you see a nice healthy ankle. This space in between the bones is not space. That space is cartilage. And so there's no space in our ankles. We have some cartilage in between the bones. When you see an x-ray like this, where there's no space between the bones, the cartilage is gone. That's bone-on-bone arthritis. So weight-bearing x-rays really help us to see what your ankle is going to look like when you load it. Sometimes you've had an x-ray done somewhere else, and your provider might want weight-bearing x-rays, and it's totally appropriate to repeat those with weight-bearing because it changes what we see with arthritis. CT scans, we don't get CT scans in everybody. I get them when I'm not sure about the other joints. And so I mentioned at the start of this talk about the ankle joint, the subtalar joint, the transverse talar joint. I can see the ankle joint pretty well on x-rays, but some of these lesser joints, like the subtalar joint, these are hard to see. And so I might want a CT scan. Your provider might want a CT scan to look at these other joints to see what else is going on with your arthritis. Do you need more than one joint addressed? MRIs are uncommon when it comes to arthritis, but we'll get an MRI if we're not sure about the diagnosis. If you have some tendon pain and some arthritis, and we're trying to figure out which is which one we want to treat first, we might get an MRI. MRIs are very helpful if you have a history of infection. And most important, when we talk about ankle arthritis, an MRI can really help us to see if you have good blood supply to your bones. And so if you look at this right-hand image, you'll see most of the bones are nice and white on this T1 image, but this ankle bone is black. Why is it black? It has no blood supply. And so this is a poor foundation. And if you have an ankle bone that has lost its blood supply, typically secondary to trauma, but there can be other causes of avascular necrosis, steroid use, etc. If you have poor blood supply, it really limits some of your surgical options for ankle arthritis. And so an MRI is important in those situations. And now we're mostly logged on here for treatment, right? What do we do about ankle arthritis? So let's get into it. These are my treatment goals. I want to decrease your pain. I want to increase your function, get you back to doing things that allow you to be healthy and active here in the Sierra. If you have deformity, we want to correct your deformity to prevent further problems. We want to make sure your ankle is stable. It needs to be stable underneath you when you walk. Your ankle needs to be shoeable. That means you can wear a shoe. It might not be your favorite shoe, but it can be a shoe that you can wear around town, go hiking in. You want to be able to fit your foot into a shoe. And if not, at least braceable, where you can get your ankle into a brace to make up for some of the deformity you might have. I mentioned that I'm a member of the American Academy of Orthopedic Surgeons. And so this is an article from our journal, the Journal of the American Academy of Orthopedic Surgeons. If you're someone who's going to dive into the literature to double check the things you hear and see, I think that's great. I do think you have to be careful about what you read. But anything from the American Academy of Orthopedic Surgeons is going to be something that's peer reviewed, meaning that before it's published, it gets presented to several other doctors, and we make sure that it's reasonable, that it's not biased. So this is a good journal to reference. And this is just a chart that talks about some of the various non-operative treatments for ankle arthritis, and we're going to get into them. I don't really get into lifestyle changes. I think most of you know that, right? If there's something, if your ankle arthritis only bugs you when you do one specific sport, can you give up that sport and then move on with your life? That's a viable option. But the rest of this I'll get into, from orthotics to the anti-inflammatory medications to injections. and to physical therapy. And so I'll start with physical therapy. Going back to my treatment goals, right? Decrease pain, decrease function, deformity correction. I'm going to show this slide for everything that we do and talk about how they address those specific factors. So physical therapy works. A lot of people with ankle arthritis have decreased motion. They can help you get your motion back. Sometimes you have decreased stability, whether from ligamentous injury or muscle imbalance. They can help you work with the muscles you have to regain your stability and improve your function. And if you get more active and your function improves, you can lose weight, and that can decrease your risk of arthritis. So physical therapy has a absolute role in ankle arthritis. If you're limited, Tahoe has so many great therapists. And so physical therapy definitely has a role in your treatment, and I would consider it. Braces, look at how many boxes the braces check. So just about everything with the exception of deformity correction, braces are a great option. I have a number of braces on here. Sometimes when you have a flare up or you first see a doctor, they'll put you into this CAM boot. It's called a controlled ankle motion boot. These are temporary devices. If you're in a CAM boot longer than 6 weeks, you're in it too long. It throws off your gait. It can cause knee, hip, and back pain. But temporarily, a CAM boot might be a good option. You may have gone to see someone for ankle instability and they gave you one of these stirrup braces. They're fine temporarily. The next brace you see is an Arizona brace. I'll go into this more, but these are typically made for you. These are braces that they mold for you. They lace up like a stirrup, and they're fantastic braces for arthritis. Sometimes your arthritis is mild and due to your foot's in a little bit of valgus or pronation or varus or supination, and we can give you a little orthotic in your shoe just to get your foot back into alignment, and that's all you need. We can also modify your shoes. Now, this is an older picture. We can modify any good shoe you have. If you have a shoe that's made of leather, we can take it to one of our brace shops. We can add this rocker bottom to your shoe that you like. And that rocker bottom is going to roll through. So instead of your ankle having to go through 35 degrees of motion, the shoe will do it for you. So modifying your shoes is a great option for ankle arthritis. And so don't be afraid of braces. If you come to my clinic for ankle arthritis, you probably have heard me say, I would rather modify your shoe than you any day, right? You can always change a brace, but once you've had your foot modified, that's surgery. So consider braces. They're a viable option. And I've had some patients get a brace that works for them, and they're like, I'm good, doc. I don't need anything further. So braces work. Assistive devices. I don't see enough of this in Tahoe. If you've ever been in Europe, everyone hikes with walking poles. When you put that pole into your hand, it takes 30% of your weight off of your ankle. It really offsets the weight across your ankle joint. So hiking with walking poles early in ankle arthritis can slow the progression of disease, can make you more functional. You still get all the health benefits without the stress on your joints. Um, I really encourage people to consider walking poles who have mild to moderate ankle arthritis. I get it. You have to remember to bring them. My wife and I both have them. We don't use them enough. But I think assistive devices are a great idea. Even a cane. If you have moderate to severe arthritis, a cane sometimes is all you need to unload your joint and prevent the need for further surgery. So canes can be a great option as well. Anti-inflammatories. If you can do the things you want to do in life and you have to take the occasional Motrin, do that. That's amazing. That's so easy. So you have ankle arthritis sometimes, but if you're gonna go for a long hike or you're gonna go skiing with friends, you got to take some Motrin or naproxen or name your favorite NSAID. Do that. That's a very healthy option for you. Now, if you find that you have to do this every day, well, that can have side effects. And I think these are very real side effects. I have had patients in my clinic who have developed stomach ulcers from taking anti-inflammatories too often and too much. I've had patients in my clinic who have developed acute and chronic kidney injury. That's scary. So that affects your renal function by taking too many anti-inflammatories. And so I think this is great on a limited basis, but if you find yourself taking anti-inflammatories on a regular basis, I think you really need to consider other options for your ankle arthritis. It's great on occasion, but just not every day, all day. Herbal supplements, health food store. And I think some of you may on here may have some great experience with these, and love to hear your experience. I'm happy to hear it and have you share it. Um, what are we talking about here? We're talking about glucosamine, chondroitin sulfate, shark cartilage. If you go to the GNC, you'll find a million different products out there that are recommended for ankle arthritis. And the idea is that if you consume these items, it'll give your body what it needs to grow or preserve cartilage. Sadly, our current literature has not proven this to be effective. It's not more effective than placebo. So for me, from the American Academy of Orthopedic Surgeons, we don't recommend it because it just hasn't been proven for any joint to be effective. Now, if you as an individual have had good success with it, absolutely do it. As an aside, my old man had terrible hip arthritis, and I had him on this, and he felt it was helpful. But as a provider, I'm not going to recommend it because it just hasn't been proven in the literature for you to take herbal supplements. Again, if you had a good experience with it, do it. If you want to share your experience, we're happy to help share that tonight as well. Steroids work. So who gets steroids in my office? Steroids are a high-powered anti-inflammatory, and we inject them right into the joint. You walk out of the clinic, you feel better that day. You feel better. Most people say the first injection, 3 months, 6 months. Steroids work, but steroids are not amazing. These are dumb bombs. I put them into your ankle, and steroids break up all the scar tissue, but also some good tissue too. They're chondrotoxic. It's bad for good tissue. We don't want to give steroids to patients who have healthy cartilage. And so if you have mild or moderate arthritis, we're not going to recommend steroids. It's really for those patients who are considering surgery because steroids are a very valid option. If you can get a steroid injection one time a year or every 3 months, that's great. That's probably cheaper than surgery and keeps you active. I've had plenty of patients who come to me yearly or 3 or 4 times a year for steroid injections. Now, as you see on the slide, they have diminishing returns. What I do see is over time, you need the steroids more and more, and they last less and less. And so at some point, you'll probably have to do something different, but they can buy you time. And so if you have terrible ankle arthritis, you're thinking about surgery, a steroid injection is a very valuable thing to consider to buy you time. It doesn't cure anything. Again, it just buys you time. Hyaluronic acid. There's a number of products out there that have this. What is hyaluronic acid? It's a substance in your ankle cartilage that binds the proteins and helps cartilage grow and mature. Um, Similar to what we talked about with some of the GNC health food things, uh, this is different because we inject it into your joint right where it's needed. You're not trying to bring this through your gut into your joints. We put it right where it's needed. And this has been studied extensively. Animal studies have shown that this can be chondroprotective, anti-inflammatory, as shown in the slide. There have been good studies in the knee with specific doses that have shown that this is effective in knee arthritis more than steroid. So this is FDA approved, not just as a product, but as a procedure for knee arthritis. For the ankle specifically, however, we just don't have great studies. We don't know the exact dose for the ankle. It's a smaller joint than the knee. And we don't know the severity of arthritis that is helpful. And so the procedure has not been FDA approved for the knee. And so for that reason, I put that on here that this is a valid thing to try. We don't know the exact dose that's helpful for you, but it is safe. The problem is that it's not FDA approved, and therefore your insurance company will not approve it or pay for it. They will pay for your office visit, they will pay for the injection, just not the drug. And so for patients who have mild to moderate arthritis that would like to try HA, they've had success in their knee, or they've had friends with success with this, we'll certainly do it. What happens is you often have to buy the medicine yourself and then bring it with you to clinic to have it injected. Uh, Cost wise, I don't know the numbers for every drug out there. I think the cheapest we've seen is about $300 for a series of 3 injections. So it's not cheap, but it has been studied in other joints, and I do provide this because it is FDA approved for the knee, just not specifically studied for the ankle. So this is orthobiologics. I think this is the future. What we're talking about here is platelet-rich plasma and stem cells. So platelet-rich plasma or PRP, I have a few pictures up here that show how that's done. Basically, we draw blood from your arm and we put into a centrifuge and we separate the red blood cells from the plasma and the platelets. Plasma and platelets is what heals you. If you ever cut your arm before, it's platelets that heal you. And so the same thing, we separate the red blood cells from the plasma and platelets, and then we inject the plasma and platelets back into your body part that we're trying to heal to kind of kickstart that healing process. It's a great idea. It makes a lot of sense. All of the devices are FDA approved, the PRP machines. It's just the procedure itself. We don't know the exact dose. We don't know how many platelets are necessary. And so the actual procedure is not FDA approved yet. And so your insurance company will not pay for this typically because it's not been approved in terms of that yet. There's a lot of companies, a lot of different products. All the centrifuges are a little different. So it's safe, not quite approved yet. And it can be costly. I've seen prices around $1,000 for platelet-rich plasma. There are providers at Barton who do this, and so if it is something you're interested in, we can get you in touch with somebody to talk about the risks and benefits for your specific situation. Stem cells, I don't really go into the slide on that. Stem cells are different. Stem cells is very similar, but instead of grabbing blood from your vein, we're going to harvest bone marrow or adipose tissue. In a similar process, we're going to centrifuge it to isolate the stem cells, and then hoping that these stem cells can go in and grow or heal things. There's less data on this, and it's much more expensive. Um, it is typically a safe procedure, but again, just not studied enough to be FDA approved. And so for that reason on this slide, for our objectives for treatment, I left everything as a question mark. So we just don't have the data yet as to what concentration of platelet-rich plasma or stem cell you need to be effective, and is it effective at all going forward. So it's an option for you, but again, the studies are just not out there yet. So that brings us to surgery. We've gone through non-operative management, we've gone through injections. The final arm of our treatment paradigm is going to be surgery. A number of surgeries are out there for ankle arthritis, and a lot of patients ask, when should I consider surgery? I think this is the minimum criteria. I generally tell people only consider surgery if you can't do the thing that makes you you, and it's possible to do it after surgery, right? So if hiking in Tahoe is the thing that makes you you, and you're taking NSAIDs and using the poles, and you tried braces, and you can't do that, and this is why you live in Tahoe, and this is part of who you are, part of your relationship with your significant other, well, then maybe it's time to consider surgery so you can do that. So the other criteria I would use is this 30 minutes of exercise. If you can't exercise for 30 minutes 5 days a week because of your arthritis and you've tried everything else, maybe it's time to consider surgery because we know from the American Heart Association that that's the minimum criteria to be healthy, to prevent cardiovascular disease. You've got to be able to exercise. So if you can't exercise, consider surgery. The minimum of non-operative management would be 6 months. I mean, you really need to give non-operative management a try before you consider surgery. And I'm a surgeon telling you this, so it's real. Um, some of the surgeries we have are rather benign. If you have mild arthritis and we look at your x-ray, and I circled it here in this x-ray, this big bone spur this patient has, where they've formed mostly arthritis anterior medially. They're in the early stages of arthritis. It will get worse, but this is where it's presenting, and they're getting a lot of pain when they try to bring their ankle up on that bone spur. Well, I can put a camera in, I can trim down the bone spur, I can do some minor cartilage restoration in the ankle. So for mild arthritis, you can do this with a minimally invasive surgery, and this is not going to buy you forever. If you're starting to form bone spurs and have arthritis, it's going to get worse with time, but hopefully we can get you another 5 years, maybe 10 years from doing some of these debridement or cleanup procedures. If your ankle is out of alignment, like that car tire I showed you earlier in the slideshow, so this patient, their ankle is in varus or supination, and they're mostly getting arthritis here on the inside because of the position of their ankle. So if your ankle's out of alignment, we can perform an alignment correction surgery like this, where we bring your ankle down into a neutral position, and that's going to change the force vector. So you're not walking on this part of your ankle anymore. But this part of your ankle where you have healthy cartilage, again, it doesn't cure you, but hopefully can buy you another 5 to 10 years. And if you're ever going to consider having a joint replacement, this puts your ankle in a better position. So this is a great surgery to consider if you have moderate severe arthritis that's affecting only part of your ankle. We can realign you to get your ankle back into better alignment. Fusion is the next thing I want to talk about. So now we're getting into the two mainstays of ankle arthritis treatment and ankle fusion. You don't hear about this with hip and knee arthritis, and I think that's obvious, right? If you fuse your hip in one position, in a seated position, you wouldn't be able to walk. If you fused your hip or knee in the walking position, you wouldn't be able to sit. The ankle is different, right? Because you can fuse your ankle in a 90-degree position and you can still sit, walk, drive, etc. So the ankle can be fused. This was considered to be the gold standard for years, and now it's considered to be an equal gold standard with a replacement. But fusions work. They check all the boxes here in our treatment paradigm, right? Um, they're not without their problems. We're trying to fuse two bones together that don't belong together, and so non-union can happen up to 10% of the time. We have some good studies out of Iowa of patients who had ankle fusions, and we look at them 20 years later. We know that all of those patients are going to get adjacent joint disease, but only 3 to 5% of them will go on to have any further surgeries. And so fusion's a good option. It lasts forever. It has very low risk. Who should consider a fusion? If you're a young patient, I'm over 50 now, so it bothers me, but if you're a young patient less than 50, and you're still active, you're in construction, you're working on your feet all day, every day, and you have terrible arthritis, you should think about a fusion, not a replacement, because this is your Honda Accord. It's not gonna break down. So this fusion's gonna last you forever. You can jump on it, you can walk on it, you can stand on it. Once it heals, it's not going to have problems for you. Um, if you have a complex deformity, we're like, oh, you have a bad deformity of your ankle and your subtalar joint, your transverse tarsal joint, a fusion is a simple answer to solve that complex problem. So fusion's a good option for you. If you are at risk for wound complications, and patients at risk for wound complications include patients with diabetes, patients who use a lot of tobacco products, prior infections, poor vascularity. If you have a lot of risk, a fusion is a good option because we can perform a fusion through poke holes. This is minimally invasive. We get small incisions, we can prepare a joint, put screws in with very low risk to you. So fusion's good for patients who have high risk with surgery. After a fusion, you'd be surprised. If I lined up all my patients who I've fused over the last 20 years on a football field and had them walk across the football field and had you try to tell me which ankle was fused, you wouldn't be able to do it. They look good. You look good with the fusion. You can walk fairly normal at a normal stride. When you do try to walk quickly or jog, you'll see the difference. But walking, patients with a fusion can walk fairly normally. So you can walk, you can hike, you can ski, you can bike, golf, swim. I really haven't had fusion patients run. Some of the papers we'll look at here in a bit have discussed that, but typically I tell patients with an ankle fusion, you're just not going to be able to get back to that. It's just too stiff for that. Um, Next, ankle replacements. So ankle replacements are not new. They've been around for a while, but these are getting better and better. In orthopedics, we talk about the generation of ankle replacements. And when I trained, 20 years ago, we were in our second generation. Now we're in our fourth generation of ankle replacements. They're getting better and better, lasting longer and longer. Um, and so what are we doing? We're taking your bone that has arthritis and we're replacing it with metal on each end and a piece of plastic in the middle that acts as your cartilage and allows your ankle to move without pain. And this is what it might look like. So here's an ankle with arthritis. I've shown you this image. We remove the arthritic portions and replace it with metal, and plastic, and that allows your ankle to move without pain. So it's a great option, very similar to knee and hip arthritis in terms of how it works. And it checks all our boxes, right? It decreases your pain, corrects your deformity, lets you wear shoes, a brace if you need to. Ankle replacements do great. They have their own specific issues here. This is a mechanical part. So I think you heard me refer to an ankle fusion as a Honda Accord. I would say an ankle replacement is more of your European sports car. It's amazing. It's going to run better than your Honda Accord, but it's going to have a few issues during the time that you have it. And so there will be times you have to go back and have some revision surgeries. Typically not replacing the whole ankle, but maybe going in and getting a bone spur. You can see this ankle, how that bone might continue growing and cause some issues in that gutter. These are issues unique to ankles that you don't see in hips and knees. Um, who gets an ankle replacement? In general, we're looking at older patients or patients who are less active. You shouldn't be in active labor anymore, not a roofer, not a contractor, not a in construction or yard work. But you can still be actively employed, just not that kind of a job. You have to have good alignment. This is a mechanical part, and if you put a mechanical part into something with bad alignment, it's going to fail. That car tire I showed you, if you don't correct the alignment, you put a new tire on there, the new tire is going to fail too. So you do have to correct the alignment before you put in a mechanical part like an ankle replacement. You cannot be a smoker. The risk of tobacco use and surgery for something like this is too high. You will have wound problems if you do that because the nicotine in the tobacco closes down the small vessels and really makes a wound healing a problem. You really cannot have an active infection, and I would caution against any prior bone infection in your ankle. And you got to have good bone stock, right? We're building a house. It has to have a good foundation. If you build this on sand, it's going to fail. So you have to have good bone stock for an ankle replacement. Uh, Again, another article from the Journal of the American Academy of Orthopedic Surgeons, a very recent article looking at 3,000 patients 6 years out from ankle replacements, and they do well. So 92% of patients still were preserving their ankle replacement, going on with their life, doing the things they want to do. But look at this revision rate, 23%. How do those numbers add up? As I mentioned, not every revision is for taking out the prosthetic and putting in a new one. It might be a bone spur, it could be a symptomatic scar. So there are other things that have to be done to maintain this mechanical part during that time, but we can maintain ankle replacement, but you will require maintenance and regular observation during the time that you have an ankle replacement. So how about sports and ankle replacement? So this was a good study. A systematic review means that these authors went in and they looked at all the papers out there on ankle replacements and sports. A meta-analysis means they looked at those specific studies that are good. They're prospective, randomized, good quality evidence. But they looked at all that and they said, you know what, after ankle replacements, you can expect to get back to sport, cycling, swimming, hiking, skiing, tennis. They looked at two studies specifically that found no association between a return to sport and failure. So don't be afraid to get back into sports. It's not associated with failure of your ankle replacement. You can do those things. It's not all rose-colored here. When you look at this in yellow, these are the patients who wanted to get back to sport that could not. And so, really, of all the patients who wanted to ski after ankle replacement, only 40% got back to skiing. Tennis 20%. And jogging, again, I have not seen this in my practice, but 15%. And so, yes, you can get back to sport. Not everyone does, though. And that can be multiple reasons, but I think that's good data from 3,000 patients, 11 studies. So it's something useful to look at. So now you have end-stage arthritis and you've gone through everything. And you're like, what do I do, doc? Do I replace it or do I fuse it? That's a great question. Let me just start with sports. All right. When you look at sports, this was a good study, not a huge study, 20 patients in each group, but 3 years out from surgery. So that's a good time frame to look at this. And they found no difference in return to sport between ankle replacements and ankle fusions at 3 years. They found that about 75% of people got back to the sport, to a sport, maybe not the sport they wanted to, but a sport. And patient satisfaction was good, 85%, not great. I think anyone who's an active athlete who gets arthritis, you're not going to be 100% satisfied, but good satisfaction with what you can do after these surgeries. And here's the sports, basically the same in each group, maybe not the same amount, but the same sports in both groups, cycling being the first sport in both groups. The Academy put out this nice chart that I think can help you in making that decision. So ankle arthrodesis is another name for a fusion. Certainly, ankle arthrodesis, as I mentioned, has a lower risk of surgery. It's a simpler surgery, lower risk. Ankle replacement gets you your motion back. We have plenty of studies that show that your stride, your walking cadence, going up and down stairs, all better with ankle replacement because you have motion. So no doubt about it, ankle replacement gives you motion, a fusion does not. Um, High demand patients, these are the laborers, better for a fusion. Fusions have a lower risk of infection, so small incisions, poke holes typically. Um, Adjacent joint disease, I mentioned that from the study in Iowa. If you have a fusion, you will get adjacent joint disease. And ankle replacements should not get that because you're maintaining your motion. Uh, if you have neuropathy, if your muscles are out of balance, you should do a fusion because an ankle replacement is going to fail due to the abnormal pull of your muscles. If both sides are affected, though, do a replacement because you really don't want to have a stiff ankle on both sides. Both sides are well studied, both surgeries. Uh, an ankle fusion can have a non-union, an ankle replacement can have failure. So, nice chart that kind of goes through these things. Probably, though, doesn't answer your question. Should you get a fusion or a replacement, right? Um, I like this test. This is called my temporary fusion test. I mentioned this Arizona brace. If you come in and you're trying to make that decision, I'll often say, try a brace. I have had patients with terrible arthritis put on this ankle fusion brace, the Arizona brace, and they're like, you know what, doc? I'm good. I can put this on. I can do everything I want to do. I'll see you later. The brace can be effective by itself, but more importantly, it can also be a test. If you wear this brace and you do all the things you want to do, well then consider a fusion. If you wear this brace and you can't do the things you enjoy because of lack of motion, maybe you need to lean towards a replacement. So it's a good test to wear this Arizona brace temporarily. I mentioned my Foot and Ankle Society. We have this web page. If you type in Foot Care MD, it'll take you there. And this is a great site that has patient testimonials. And so Earl's story, he talks about his ankle fusion. You can watch him walk. Nancy has an ankle replacement. You can watch her walk. They show their ankles. They talk about their experience. It's a great website to log on to, not just for fusions or replacements, for just about any foot and ankle condition you have. Really recommend going to this website and seeing what's out there. Uh, Come see a specialist, right? If you want to talk about your particular case, I think come see me. We'll talk about it. I'll be honest with you. I'll talk about you, your risk factors, what I think is best for you. Tahoe is a small town. We're going to see each other around town. So I want what's best for you. So come see me or another specialist and talk about your particular case. It's a great way to get more information about your particular case. And that's it. I think uh, I have our office locations here, and then I think Natasha's going to run the question and answer period here. If you have any questions for me or want to share something that I didn't share, I'm happy to hear from you about your experience with ankle arthritis.
Thank you so much, Dr. Ryan. Just as a reminder, if you have questions, you can ask them in the Q&A box at the bottom of your Zoom screen or in the chat box. But while we wait for those to come in, do you want to just talk a little bit more about the rest of your practice, other sorts of injuries or things you might see, just to let people know?
Yeah. So orthopedics is different. I know our practice, we're taking care of pretty much anything orthopedics. We've grown. So I've hired, well, I didn't hire, Barton hired a PA, Jenna Jermise Mame. She's joined us, so she's a PA and she's taken over a lot of the non-operative aspects of our practice. So if you're having minor aches and pains, plantar fasciitis, Achilles pain, that doesn't need surgery, but maybe need physical therapy or orthotics, we can see you. We've expanded our access to care in that regard. And so pretty much anything foot and ankle that's bothering you, we can take care of. We don't do a lot of the podiatric care that you might know about, like nail care or calluses or corns. Um, but anything that might need physical therapy or orthotics, shoes, braces, surgery, we can definitely kind of get you in the right direction in that regard.
Great. We've had a couple questions come in. The first one is asking, what does the PT look like following a fusion compared to a replacement?
That's a great question. So when I fuse the joints together, I really don't want any motion until those bones knit together. And so I do put my fusion patients into a cast for 6 weeks. And so that can be something you have to get your head around to cast it and kind of keep it immobile for 6 weeks so the bones will knit together. Because if there's micro motion, it might not heal. When I have patients in a cast, there's a number of devices that I recommend you use to get around town. I'm sure you've seen my patients mostly on those knee scooters. So it's a knee scooter. You have handles like a bicycle. You put your knee on it. You can scoot around town. If you're in your house, you can sit on it. So knee scooters really help you get around during that 6 weeks. Um, there's another device out there called an iWalk. So if you have to use your hands, I've had plenty of bartenders and some electricians have ankle surgery to go into a cast, and they'll use this iWalk, which is like a pirate leg. If you type in the word iWalk, lowercase I walk, you'll see it. It's a device you can use to get around and do the things you need to do. You can walk in snow up and down stairs with that. So two things you can use to get around. But after a fusion, it is a cast for 6 weeks. An ankle replacement is different. I want to move that ankle replacement. And so I do put you into a cast for 2 weeks, not 6 weeks. And that's not for the replacement, that's for the skin. It's a big incision on the front of your ankle, 15 centimeters to put an ankle replacement in. And I need that skin to heal nicely. So I cast you for 2 weeks to let the skin heal. Once the skin heals for an ankle replacement, you go into a boot, and you can be 30% weight bearing for the next 6 weeks. The metal that we use, and I'm going to just backtrack my slides here a little bit if I can, um, to the picture of an ankle replacement. And so the metal that we use, it has trabecular metal on it, and you can see the porosity of this metal. Your bone is actually going to grow into this replacement. I don't use cement or anything else to heal this to your bone. I'll let your bone heal into the prosthesis. The bottom of this also has trabecular metal. And so 30% weight bearing allows your bone to heal into this. If it's full weight bearing, it might be too much, it won't heal. And no weight bearing won't let it heal either. So 30% weight bearing in a boot for 6 weeks. So ankle replacements can move right away, can walk right away. My ankle fusions, it's a cast, non-weight bearing for 6 weeks. So a little bit different there in the initial therapy. After 6 weeks, the therapy is the same.
Great. The next question, does having an elected fusion procedure preclude the application of ankle replacement surgery in the event the fusion procedure proves to be unsatisfactory?
No, thanks for that. I actually had that slide in here and I took it out. But I wish I'd kept it in now. So yes, you can flip flop. And so if you've had an ankle fusion and you have a painful ankle fusion, there's a number of reasons to have that. It could be micromotion or non-union. It might be pain at one of the adjacent joints. Sometimes someone will have a very successful ankle fusion for 15, 20 years, and then they start getting adjacent joint arthritis, and they have to make that decision. Do I fuse more joints or do I transfer over to an ankle replacement? But you can absolutely have an ankle replacement after an ankle fusion. Imagine that this bone here is fused with screws. We take out the hardware, we remove a box of bone here, and we put in the ankle replacement. So it works very well. It offloads the other joints that are having adjacent joint pain. It's a great option for painful ankle fusion. The one caveat I would say is you might not get the same motion back that you would have initially because all of your tendons that go across your ankle have been locked in one position for years. And so those tendons get kind of scarred in. So even though your ankle can move, your tendons might not move very well. So it takes time to get your motion back. But you can absolutely change an ankle fusion to an ankle replacement. And vice versa. You can take out an ankle replacement and put in an ankle fusion. That's a little trickier, but it can absolutely be done if necessary.
Great. I think this is the last question, but if you have one, get it in there and I'll ask it. Does wearing super cushioned footwear like Hoka's help worsen instability? Or what factors should be considered when choosing shoes for someone with ankle arthritis?
Um, I do like the super cushion, the shoe wear. I think it's been a game changer. And I think Hoka was the first one that was widely available in the market. A number of companies now have mirrored that design. What is that design? For those of you who don't know, it's a very thick cushion on the bottom of the shoe, and a decreased drop. The drop is the percent from the heel to the toe. Most modern shoe wear that began in the 70s, 80s had about a 12-degree drop so that you're designed to hit your heel, roll through to your toe, but it forced your foot through that drop motion. The Hoka typically had about a 4% drop, so a little less drop, so it allowed your foot to kind of hit in the midfoot of the foot, and a super cushioned sole and a little bit of a rocker to it, similar to that shoe I showed you in the talk, a little bit of a rocker that allows the shoe to glide. And as I mentioned, there's two or three companies out there now that are making very similar shoes. And so if you like that design, it doesn't have to be that company. Any company can do it. The super cushion shoes absolutely are helpful for foot arthritis. And so if you're having grade two arthritis, midfoot arthritis, I think it's super helpful. I don't know that it's going to make a huge difference in your ankle arthritis, with the exception that a little of that cushion will take the stress off your ankle. But those shoes are better. That midfoot rocker is more designed for midfoot or forefoot arthritis, not as much ankle arthritis, but certainly wouldn't do any harm to do that if it works for you and you have concomitant foot arthritis. So I hope that answers that question.
Great. We did get one more question. Actually, maybe a couple. So hang tight. This person is asking, they have bone-on-bone knee pain. They're seeing an orthopedic specialist for, and a knee replacement is imminent, for both knees, but it's worse in the left knee. They also have arthritis, in that left foot and ankle. They're just concerned about the knee replacement and how that'll affect the ankle and foot. I'm just wondering if you can talk more to that.
Yeah, it's a tough situation sometimes when you have both the knee and the ankle, which one you should address first. Um, I think my preference when it comes to alignment, is we start, up at the spine and we work our way down to get our alignment. Often when we're trying to determine how to align joints, we're getting long leg films, where we x-ray you from the hip down to the ankle. And so it's easier to align to your body than it is to nothing else. And so I do recommend for that situation, for knee and ankle arthritis, getting the knee alignment and knee replacement done first. And then if you need an ankle, we can align it with the knee. When I put in an ankle replacement like this, you can see these little holes above it. That's from the alignment guide. I actually have a guide that I'll hook up to the knee and I align the ankle with the knee. And so if you have a knee that's off kilter, it's very difficult for me to know where to align your ankle. And so I think if both are affected, it makes sense to me to get the knee straight first and then to come down and address the ankle. So that'd be my preference. Sometimes it comes down to which one hurts you worse, which one's more debilitating, but I think it's easier to align things from the top to the bottom.
Great. Well, look, we got pretty much to the top of the hour. And you did get a shout out from the Fernandez family in South Carolina saying they miss you. So, um, thank you everyone for being here tonight. Really, really nice comments and questions. Just as a reminder, this has been recorded. You can find it on our YouTube channel as early as tomorrow or on our Facebook page. And there is a short survey at the conclusion of this webinar. We love your feedback. Let us know how we did tonight and what topics you would like to hear from us in the future. But with that, we'll let you go to get to the rest of your night. And Dr. Ryan, thank you so much for being here. We really appreciate it.
All right, everyone. Happy holidays. Bye for now.